the end. We'll move to the next speaker, another dynamic and upcoming stalwart in mix, I should say, a yo stalwart, Dr. Sahebaan Sethi, to cover on the data and something more on mix and a newer perspective.
Thank you so much, Prasanna, for having me here. And so I'm going to be talking about does minimally invasive, which is what we're talking about, minimally invasive glaucoma surgery, really does it mean less risky? So this is the other side of it. So now imagine a patient, she is 33 years old now. When she came to me, she was 30. Now she had an open angle glaucoma, an advanced one in one eye, for which she underwent a trabeculectomy and clearly understood the nuances. So she was on long-term AGMs, and you can see the anterior, the ocular surface is also compromised, but has a pressure of 29 on 4 anti-glaucoma medications, but a very mild glaucoma. So now all of us who do TRABs would know that this is a case to actually avoid TRABs as much as you can, because there is a high rate of failure in such cases. So I went ahead and did a mixed procedure in this patient, and we have a follow-up of 2 years for this patient, and the IOP is well controlled on 2 anti-glaucoma medications. So this is a long follow-up showing the success of MIGS, the avoidance of trabeculectomy, and how it has benefited the patient. Again, another case suffering from severe ocular surface side effects, and you can see how red the eye is. Again, this patient is very well controlled on the number of anti-glaucoma medications he's on, but wants a cataract surgery now. So in this case, if you do combine it with a trabeculectomy, you know again that there is a high chance of failure. And if the patient is well controlled on a few AGMs, I wouldn't really want to specifically go in for TRAB unless I'm left with no options. So now that we thankfully do have an option, the cataract surgery was combined with the MIG surgery, and the patient already with a 9-month follow-up, you can see that the ocular surface is already feeling much better. Again, another patient, a gynecologist by profession. So she underwent trabeculectomy about a year ago for corona-induced uveitis, ended up being a steroid responder. Now 5 months through her TRAB journey, she was started on anti-glaucoma medications, out of which the only one that she tolerated was tafluprost. To her dismay, that also got discontinued. Following this, she underwent a temporal SLT, and that also started failing in 3 months, and she landed up with an IOP of about 39 millimeters of mercury. Now, to top it all up, she did not have glaucoma. She was just an ocular hypertensive. Again, doing a trabeculectomy seems trabeculectomy seems a little more aggressive in this patient. So, with MIGS, she's well controlled. I have only a 6 months follow-up, and the pressure is well maintained with no medications. So, yes, we do have advantages of minimally invasive glaucoma surgery. They preserve conjunctiva if needed in the future for more advanced disease. They also spare you from sight-threatening complications, and they do have faster recovery, and the quality of life is what every patient and even the doctor is looking for their patients. And for the sake of not having a bleb, you're spared from a lot of dreaded complications like blebitis, endophthalmitis, tube exposures, overhanging blebs. Even the TVT study says that in a 5-year follow-up, the tube group has about 43% and the TRAB group has about 63% rate of surgical complications post-operatively. Now, we do not have a head-to-head comparison on how it fares with TRAB versus MIGS, but yes, the numbers that have come out of the number of complications we find with MIGS is significantly much lesser. Also, there is no chance of hypotony because the pressure reduction in MIGS is governed by the episcleral venous back pressure, which is about 6 to 8 millimeters of mercury, and with a MIGS procedure, you're never going to get something lower than that. Also, refractive neutrality. So all sorts of MIGS are fairly refractively neutral. So even if you're thinking of premium IOLs or toric IOLs, these are probably better glaucoma procedures to combine with in your cases compared to TRABs and tubes where you will be a little more mindful. Also, when it comes to patients on anticoagulants or antiplatelets, the TM bypass procedures, they still score over the TM stripping procedures, definitely more so with a 360-degree TM stripping procedure, where the hyphema can be actually as dangerous as what you would expect with a trab. So here are a few complications. No procedure is free of complications. So these are my complications that I've seen through my course of MIGS journey. So apart from IOP spikes, intraoperative hyphema, postoperative hyphema that you see in almost all cases of MIGS, you do also have times where you get overimplanted lost stents, you get occlusions, you get malpositions, you get fallout of the stents. Also, in cases of TM stripping procedures, you have rates of peripheral anterior synec, you can have an eccentric pupil, and there was a case where also there was a dispersion of pigments which went behind and affected even the vitreous. Again, even with bang, because it is a less neater cut compared to KDB, the amount of pass is probably more. So you can see a broad-based pass over here. TM leaflets also. So apart from the regular complications of hyphema, IOP spikes, inflammation, CME, and peripheral anterior synec, which has been reported with almost all cases of MIGS in literature, there are certain specific complications which apply to certain specific techniques, like trabectome can have transient hypotony, has been seen to have Descemet's membrane injury, fibrin formation. The eye stents include, of course, the stent-related complications like malposition, occlusion. There has also been reported development of cataract, PCO, iridodialysis. Even with the TM stripping procedures, the risk of bleeding is a little higher. You can end up with cyclodialysis, iridodialysis, etc. So this is my data. This is a 12-year follow-up of 30 cases of bang that is actually out there as a poster for anyone who would like to read it. And this is the multicentric study that we were just talking about. On our initial experience with iStent and iStent Inject with and without phacoemulsification in the Indian population across all severities of glaucoma. And this was done in patients who actually needed cataract surgery or needed IOP reduction or needed medication reduction. And what we see, I'm sorry for the last minute slide which is not very clear, but what we do see is that compared to iStent first generation, iStent Inject definitely brings about a much higher reduction in IOP and AGM reduction. There was about 50% reduction in intraocular pressure using iStent Injects, and also a drop of anti-glaucoma medications from close to 3 to close to 1.4. And this proved to be statistically significant. So I think from this study that we did, I can conclude that iStent is a good tool to reduce your medication burden. It may not really reduce the amount of intraocular pressure that you would be expecting.